This week on Primary Care, diabetes. It's a disease that's sweeping the nation, and African Americans and other minorities are the most at risk.
I was just saying, I'm a diabetic. Are you sure?
Hello, and welcome to Primary Care. Why are so many people, particularly African Americans, dying or suffering from complications of diabetes? According to the Center for Disease Control, if the current trends continue, by 2050, as many as 1 in 3 people in this country will have type 2 diabetes. Here to shed more light on this growing epidemic is Dr. David Williams. Dr. Williams is a practicing internist in the Detroit area and has been a long-standing stalwart for primary care and is a diabetic specialist and also a managing partner of the Phoenix Medical Group. Dr. Williams, welcome to the show.
Thank you, Dr. Joe.
David, first of all, a lot of people still confuse between the terms in diabetes, type 1 versus type 2. Will you help us understand and separate that out a little more?
Sure. The majority of patients, about 90% of patients, are type 2. That's where a person is usually overweight, they become insulin resistant, lack of exercise, too much caloric intake, and they just don't do well with managing their glucoses. And then we have the type 1 patient who is deficient insulin. So they have to be on insulin in order to survive or they will die. And they can become acidotic, as we call ketoacidosis, and those patients have to be really managed very closely. The type 2 patients, usually if they lose weight, increase their physical activity, they can be maintained with a lot of different agents, but also they may require insulin because of the insulin resistance.
Right now in the city of Detroit, as you know, diabetes is an epidemic and growing. Are you seeing an increase in African Americans coming into your practice with the newly diagnosis of diabetes?
Yes, I am. Either the term pre-diabetes, where we're catching them really early because you screen and get an abnormal glucose. Now you look at them a little bit more thoroughly, and you may find that they have hemoglobin A1C that may be elevated, but not quite meeting the criteria to make the diagnosis, or their fasting blood glucose may be a little elevated. So I'm finding an upsurge of this so-called metabolic syndrome, this pre-diabetic. If we don't nip it in the bud now and get them in an exercise program, reduce their caloric intake, then they're going to become full-blown diabetic. And diabetes is an epidemic. If we don't stop it, as you said earlier, 1 in 3 is going to have it in the next 25, 30 years. And it's going to cost the government well over $180 billion a year. In billions, not millions.
Not a small amount of money.
Not at all.
We see a lot of patients now who are interested in health and diet and exercise, but the epidemic is continuing to grow. It's interesting how we've come full circle in medical schools where 25 years ago the term pre-diabetes or pre-hypertensive was thrown out the window. Now we bring it back because it highlights and underscores an area in the patient's treatment that we really need to be looking at and following those patients early. Tell us something about the complications for the unmanaged or the uncontrolled diabetic.
Well, diabetes is a systemic disease, so it's going to affect all your organs, from your brain to your toes, as I tell my patients. It increases the risk of stroke, heart attacks, peripheral vascular disease where the arteries get plugged in the legs, causes kidney disease where they lose protein and have to be on dialysis. I mean, it's visual changes also. They become diabetic retinopathy where they lose sight, and it's one of the #1 causes of blindness in the United States.
And obesity. 58% of African American women in this country are obese. 38% of African American men. A prelude to this disease state. Not to mention what's happening in the pediatric age group where being overweight is out of control also.
Yes, it's an epidemic. So we have to do like some of the other countries, as we were talking earlier. We have to ride our bikes to work. We have to walk to church. We have to find some way to increase our physical activity. I tell all my patients, just do 30 minutes a day. I had one patient to lose weight because she liked to read the newspaper and she always had home delivery. And I told her, just walk and get the paper. And she started walking 4 blocks there and back, and she lost 20 pounds.
So most of us on this health craze in this country have a lot of the exercise equipment in the basement and in the garage, using it to store things. We're not using it properly. Right. So you're saying that encouraging these patients to burn calories is key to helping control the diabetes.
Right. And by reduction of just 500 calories per week can make you lose weight. That's a small amount. Get rid of that soft drink. Get rid of those snacks in a bag that go crunch in your mouth. You can really just eat more fruits, vegetables. I tell my patients you got to have 9 servings of fruits and vegetables per day, and you'll lose weight. And these are half-cup serving size.
Half-cup servings.
Yeah.
So in the pediatric population, again, it's almost an impossibility for a community like this to teach and educate children to eat properly when access becomes a big problem. Eating healthy is not cheap. Fast food is cheap. But if you are overweight...
In the short run.
Yes, in the short run it's cheap. But if you're an overweight pediatric age patient, you've got about a 70-75% chance of becoming a diabetic by the time you are 22.
Exactly.
And because of that, we need to be focusing more so on the prevention aspect in this disease than we do now, certainly, as opposed to waiting till the disease has sprung up and all the complications that we try to chase with all the things that we do to treat a diabetic patient. How do you advise your patients in terms of diet and obtaining the proper foods that they need?
Well, even in some of the blighted areas here in the city of Detroit where there's a food shortage area, a lot of the churches and vacant properties, people are communically doing these farms. I was just down the street on Livernois near 8 Mile at Prospect, and they have a community where they give out free food. Anybody can help clean the garden, plant the seeds, and you're entitled to it. So we can get more urban farming in the community. Ask grocers to have fresh fruit and fruit, not canned foods and fruit. And limit your caloric consumption of high carbohydrate meals, such as starchy things, such as bread, chips, crackers, etc. And get more fresh fruits. Lean meats, trim the fat off, the skin off before you grill it, bake it, or broil it. Stop frying is one of the key things that patients can do. And portion size. Portion size is the key. The amount of meat we need to consume is only about the size of the palm of the hand and the thickness of the hand, which is about 4 ounces. That 8, 12 ounce, 16 ounce steak that you get down in Texas, don't do that.
And reading labels.
And read labels, yeah. Look at the salt content, the fat. We try to keep our fat content down below 30% if we can. It's really will make a difference.
And it's something that's achievable with the proper help, with the proper education of patients and the support systems that sometimes fall apart.
Right.
Simply because we cannot get to the patients in a timely manner and in a persistent manner over time to actually get them to target or get them to go in terms of where they need to be making better choices for diabetes in terms of exercise, sleep, choices out when they eat out, how they prepare the food at home, the whole 9 yards, giving us the end result of controlled blood sugars.
Yeah. There's a book out now that patients can buy or anybody can buy. I tell them the great stocking stuffer is called The Calorie King. It gives you the fat, carb, and calories of all foods, including fast foods in chain restaurants. So patients can pick and choose before they enter the restaurant. Say, this is what I need to eat. This is lower calorie, this is lower fat. So www.thecalorieking.com. You can download it to your smartphone too.
Another tool that we can provide patients with to do a better job. We're going to go to a break. Next up, A diabetic patient tells of her surprise to learn that she had diabetes.
I did not feel anything. I didn't feel, I'm just saying, why do I have diabetes? I don't feel anything, other.
Hart, what's going on?
I'm leaving.
Why? What did I do?
Not enough. You constantly ignore me. You barely eat anything healthy. You're half as active as you used to be. The pressure is just too much. I quit.
Okay, I get it. I'll do better. Just please, don't leave.
Okay. But remember, if I go, you go.
Listen to your heart. Don't let it quit on you. Uncontrolled high blood pressure could lead to stroke, heart attack, or death. Get yours to a healthy range before it's too late.
Since 1918, the Detroit Medical Society has been there for physicians, patients, and the community. We were there then, and we're here now. The Detroit Medical Society, here for you.
Welcome back to Primary Care. Even though her mother was a diabetic, Elizabeth Barnes was still surprised when she received her diagnosis of diabetes.
Well, my mother was a diabetic, so I was just saying, I'm a diabetic. Are you sure? I did not feel anything. I didn't feel, I'm just saying, why do I have diabetes? I don't feel anything, other than, you take the needle, you stick your fingers, and and it shows that your blood sugar is up a little bit. But then I said, well, it's because of my weight. And then because at one time, I weighed more than I weigh now, and I lost that weight. But it didn't go down. About 4 years ago, that's when I started to feel the little tingling like in my foot. And then I started getting the swelling. And I thought it was because when I was younger, I would do a lot of activities and running, and I'd sprain my ankle or something like that. And I thought, my grandmother always said, when you get older, you'll feel it. And that's what I thought I was feeling. And then my toenails started getting a little thicker on some of the toes. I was to see the doctor, and he had to give me the shot for my feet because of the burning of my toes and the feeling of walking, like you feel it, like you're walking on balloons, at least to me. And what was devastating to me is that, my mother, she had amputation because what happened, her toes started and they cut the half of the foot. Then they ended up having to cut the leg, And so thinking about something like that, I don't want that to happen to me. And they told me what I should do about that. I had to keep my feet washed. I just don't put my foot in a hot tub. And I used to soak my feet. I could sit up and soak my feet for a while. You don't do that anymore when you have diabetes, but you keep your feet clean and you keep them dry. And you keep your skin cream on it so that it doesn't crack. Because the worst thing for a diabetic to do is get a crack on their foot and let infections set up in it. Your feet have to be taken care of. That's very important. Be sure you see your doctor like you're supposed to. And how you find out is start off by getting your yearly exam. Women are good about going to get the mammogram, but there's other things that you need to do. Get them to test your blood, your urine, and you can find out whatever is wrong with you. I'm blessed. I have a sister that's a support person. I have grandchildren who are support, and they'll tell me, well, Grandma, you're not supposed to have this, It's good to have somebody as a support person, because if you don't, you feel like, gee, I can do anything I want to do. And then if you have somebody to tell you, well, Liz, you can have a little bit of this, but you have to remember that you're diabetic, and we don't want anything to happen to you because we love you. Let them know that you love them. That's the reason why you're giving them that advice.
Now, Dr. Williams, Mrs. Barnes was surprised at her diagnosis of diabetes, even though her mother was a diabetic. Should she have had some hints, some tip-offs by way of just family history alone, or signs and symptoms?
Yes. Diabetes can be surprising when it becomes way out of control, but usually a patient will have symptoms. Number one, family history would alert the physician to screen for type 2 diabetes. If she's overweight as she is, would also screen for that. And most patients can have a lot of symptoms, such as blurred vision, increased frequency of urination, and females and males can even have some discomfort when they urinate, almost resembling a bladder infection, so to speak. They can present with just tingling, burning in their feet, hands, so-called stocking glove neuropathy of diabetes, feel like they're walking on balloons, pins, needles. There's a lot of things that they can that they can feel with their neuropathy, even burning sensation.
And even nothing.
And nothing.
So the family history becomes even more important to alert physician and patient that we need to be on the lookout for the development of this disease.
That's correct.
Talk a little more about some of the more devastating effects of this disease, the end organ damage, the eyes, the kidneys, the nervous system.
Yeah. So diabetes is it has an increase in microvascular diseases. So the small vessels in the brain can lead to strokes. Tiny strokes even cause dementia. In the blood vessels, you can get hemorrhages, where the eye bleeds. You can get retinal detachment, or the retina pulls away from the back and loss of vision. So all these factors can occur in somebody with uncontrolled diabetes for many years. And many years, meaning not too many years after the diagnosis, because usually by the time we make the diagnosis of type 2 diabetes, they've had it for 5 years. And that's the interesting. So now the clock is ticking 5 years later. So we usually see these complications at around 5 to 10 years of diabetes being uncontrolled. The kidneys can cause a lot of discomfort with frequency of urination, even frank nephropathy where the renal functions decline, thus causing a patient to have to go on dialysis. It usually starts with loss of urine at a very microscopic or micro level, and then it becomes frank proteinuria. So when patients look at the urine and it's foaming up like suds, that usually means they're spilling a lot of protein.
Too much protein.
And we talked about their peripheral vascular disease where they get the arteries get plugged with plaques. That also can cause an issue with claudication, meaning when they walk, they get pain in their legs, they have to stop. So that's why we encourage patients to walk. I think everybody should walk 30 minutes a day, 7 days a week, some form or fashion. Try to incorporate your daily activity around physical activity. When you go to your family reunion, just don't sit around and drink and tell jokes and eat. Get up and play a little volleyball, badminton, walk around the park, do some type of physical activity. Have a bowling night once a week. If you go to church, try to walk to church if you can. Mm-hmm. We have to incorporate walking. There was a recent study U of M did about weight reduction. I think back in 2011, where they had 2 arms to the study that showed that if a person was to follow a strict diet and no exercise, and the other arm of the study, a strict exercise program and no diet. And guess who lost the most weight? The dieters.
Interesting. So basically, the notion that you can substitute pills and get away from physical activity to treat a disease like diabetes means that we have not done a good job in treating the patient totally, getting to the point where we really need to say, listen, get up off the couch, get busy, burn some calories.
Burn some calories and really, really follow the diet.
Good. We're going to go to a break. We'll be right back with more primary care after this.
This is where heart doctors throughout the Midwest are bringing their toughest cases, where specialists from around the world come to learn, where patients who couldn't be saved before are being saved. The all-new state-of-the-heart DMC Heart Hospital. This is Detroit, rising, medicine advancing, the future unfolding. The new DMC Heart Hospital. This changes everything.
Welcome back. We're here with internist and diabetic specialist, Dr. David Williams. Dr. Williams, communication on any disease state with patients is very key. How important to you is communicating to your patient population through your staff in terms of the health care that they receive with this disease?
Very important. A doctor cannot do it by himself. He needs other allied health professionals to help him. He needs a dietitian, he needs a diabetic specialist, he needs his staff to help communicate with medications on how they take them, clarifications. Patients get concerned when they got to be put on injectable agents, etc. So we need all the support we can get.
Speaking of injectables, dispel the myth for us about the fear of needles and how patients shy away from them for years, and how the newer modalities right now have made it very easy to treat a diabetic patient.
Yeah, well, the treatment regimen of diabetes has been really improved over the last 20 years. We no longer have grandma's insulin with the big 21 gauge needles. We have very tiny needles that are 32 gauge that are about the size of a hair. So when we treat type 2 diabetes, we usually start with background therapy of metformin to help reduce the blood glucose production from the liver, and then we can use drugs to help promote insulin production from the pancreas, and we got some that are kind of smart drugs that only work when you eat, and then we have injectables. We have several types of injectables. One, the so-called smart injectable, is not insulin. We call them Glp drugs, and they're given once daily or once weekly, and they're all given in a pen device with a very fine needle, and it's user-friendly. You just dial up the dose, stick it in your abdomen, and inject it, and patients do not feel pain. Now the insulins, we have improved. We've come a long ways from the so-called beef and pork insulins, where people could develop antibodies and itching. So now we have analog insulins that are even improved over human-based insulins. They are more expensive. They all come in pens. It makes it easy. You can carry it in your pocket. It looks like a little marker.
No refrigeration?
And refrigeration for the ones you store, yes, but the ones you carry in your pocket can stay up for a month out of the refrigerator in most cases. Some up to 42 days outside the refrigeration. So patients should not be fearful of injectables. They're your friend. They get your sugars under control. They bring them down. You reduce those symptoms of the blurred vision, the increased frequency of urination. It can even help improve some of the neuropathy symptoms that you may have as your sugars get better controlled. But the biggest symptoms is the vision and urination and vaginal and penile itching.
So, better control for patients, that's the goal at the end. Talk to us a little bit about what patients should be aware of as far as testing, fasting blood sugars, A1Cs. What should they really know about those numbers? We have to reduce this treatment to numbers. What should patients know about that?
Well, fasting blood glucoses should be as normal as possible without hypoglycemia. So we set up a standards that your fasting blood glucose should be somewhere between 80 and 110. Normal is less than 100. So diabetics, we give them a little cushion. As patients get older, we may raise that cushion up to 120, 130 to prevent hypoglycemia. Because hypoglycemia is a real fear. When your blood sugar drops, you can have convulsions, you can pass out, have a heart attack, and even die from a low blood sugar. So our goals are that, our postprandial glucoses and those that are done 2 hours after you started eating should be less than 140. Your peak glucoses should not get above 180. And your A1C, which is an average of what your blood sugars over a 6 to 8 week period, should be targeted at less than 7 by ADA criteria and less than 6.5 by ACE criteria. So we know normal hemoglobin A1C is less than 5.7. We try to get you as close to normal as possible without hypoglycemia. There's been several studies in the past where patients got too well controlled and had events and it made people back off. But I encourage my colleagues to go as low as you can as long as you don't have hypoglycemia. You got to individualize. Some patients you got to keep them at 7.5 because if you try to tweak it any lower, they just bottom out and they don't do well.
No cushion.
No, right. So you got to individualize your approach to treatment of your patient. So remember, less than 7 for your hemoglobin A1C is targeted by the ADA, less than 6.5 by ACE guidelines, and your fasting blood glucose should be less than 110, and your postprandials less than 140.
Very good. Thank you, Dr. Williams. Hope to see you on the show again.
Okay,
Great.
thank you. Please invite us back.
I'm Dr. Lonnie Joe, and this has been Primary Care. Thanks for watching.
Primary Care was produced with the participation of the Detroit Medical Society, representing physicians, patients, and the community.